Good morning, afternoon and evening. This is the conference operator. The European School of Oncology welcomes you to their 331st T Grand Round. Today's session is Radiotherapy-related skin reactions, held in collaboration with EONS. Questions will be received by Mrs. K. Leonard, of the St. Luke's Radiation Oncology Centre at St. James's Hospital, Dublin, Ireland, who will discuss them with Dr. Lena Sharp, of the Regional Cancer Centre, Stockholm-Gotland, Stockholm, Sweden. I will now hand over to Dr. Sharp. Doctor, your line is now open.
Hello everyone and good evening. My name is Lena Sharp. Thank you for the introduction. I am a cancer nurse and a researcher, and the topic we will cover tonight is radiotherapy-related skin reactions. First, I have to apologize for my voice. I have a really bad cold, so I hope my voice will last for the session, but I will do my best. Okay. This is the topics that I will cover during this session. Start to talk a little bit about radiotherapy-related toxicity, but the main focus will be acute radiation skin reactions or radiodermatitis, the mechanisms, the risk factors, the management, and also a little bit about combined treatment and late skin toxicity, and a few words on assessment before the take-home message. If we start with radiotherapy-related toxicity, that is actually the effect on normal tissue. So it's not the tumor tissue, it's the normal tissue. And you can divide it up into acute and late toxicity. The acute toxicity is what you see quite early during the treatment period. It normally starts 1 to 2 weeks into the course of the treatment and continues and accelerates and then peaks a week or 10 days after the treatment and then eases off. And the late toxicity can start from weeks after the treatment to years after the treatment. And the late toxicity, it's more rare than the acute toxicity. It's more common and affects most people, the patients that undergo radiotherapy. And the acute toxicity can be really uncomfortable and create a lot of difficult symptoms, but generally resolve. So, but this causes a lot of the hospital admissions, for instance. And the late effects, they can be devastating and permanent and also progressive and very difficult. But as I said before, they're much rarer. And also with the modern radiotherapy techniques, you see less and less of the late toxicity. And the tissues that are mostly affected by the toxicity is the tissue that divide rapidly. For instance, the skin and the mucosa. And in the early days of radiotherapy, one of the limiting factors was the skin tolerance or lack of skin tolerance. That was a real problem, and this hurdle was at least partly overcome by the introduction of fractionated radiotherapy, which means that you divide the dose of radiotherapy into several smaller, often daily doses sessions, rather than give the whole planned dose in one occasion. So the repeated small doses are less damaging than a single fraction with the same total dose. And the therapeutic mechanism is based on the ability of the cells, the healthy cells, to repair damage on and get back to basically normal to the next session. But of course, we still have a problem with skin tolerance. It's still the reason why, one of the reasons why we sometimes need treatment interruptions, which is a big problem in radiotherapy. To have a treatment interruption can have a negative effect on the outcome of the treatment, so that should be avoided if possible. If we move into acute radiation skin reactions then, or radiodermatitis, this is a very common side effect, and about 80 to 100% of all patients that undergo adjuvant or curative radiotherapy experience these side effects to some degree. Most of the patients have mild reaction that doesn't affect the quality of life so much, but also a quite big part of patients experience more severe reaction. And mainly that's patients that have head and neck treatments or treatment in the pelvic area, but also it could happen to other patients as well. And those more severe reactions are associated with difficult symptoms such as pain, sleeping problems, itching, infections, and in worst case, interruptions of treatment. And what happens in the skin when you have an acute radiation skin reaction? And for that, you need to go back to this picture you see on the right, that you probably remember from school. It's the skin and the 3 layers of the skin: the epidermis, the dermis, and the hypodermis. And the epidermis is the surface of the skin, and skin cell peels off all the time, and you see the thin layer between the epidermis and the dermis, which is the basal layer. That's where new skin cells are produced in that layer to replace the ones that peel off. So that's a constant process that goes on. But when you reach 4 or 5 weeks into radiotherapy, or 45 to 60 grays of treatment, this new production of new cells goes down and eventually stops if you continue with the treatment. So you have no new production of cells, but you still keep peeling cells on the surface. So in the end, if you have a high dose enough, all of epidermis actually disappear. And when you see a moist desquamation, it's actually the basal layer and the dermis that is exposed. So that's what's happened. And this takes a few weeks after the treatment is finished, before this process is back to normal again and the skin can heal. And what you see first is erythema, different degrees of erythema, everything from light pink skin to really dark, intense red skin. And after that, if the reaction continues, you see a dry desquamation where the skin starts to be broken. And if it continues more than that, you see a moist desquamation, which is very likely to cause infections. And in very rare occasions nowadays, but you also can see it is, if it continues even more, you can see a necrosis in the area that's been treated. Is it any questions at this point? No questions? Then we continue. We continue to talk about risk factors for acute radiation skin reactions. Well, when I started radiotherapy in the late 80s, we didn't know this much about skin risk factors. We knew about the radiotherapy-related skin risk factors, but not so much about the patient-related risk factors. But if you look at the radiotherapy-related risk factors, it's of course the dose. The higher dose you give, the higher the risk is for intense reactions. And also the treatment time and the volume you treat is important. And also what technique you use for radiotherapy. If you use techniques such as bolus or boost, or use some type of immobilization device, you may increase the risk of getting severe skin reactions. And on the other hand, if you use another technique called IMRT, you may reduce the risk of skin reactions. So that all depends on the technique. There are also other risk factors related to treatment, but other treatment than the radiotherapy. For instance, previous or concomitant chemotherapy, hormone therapy, or targeted therapy. But here the data from the research is more conflicting. So some studies show that these factors are a risk factor, and other studies show that they're not. And the same goes for the patient-related risk factors. There's quite a few studies now showing the high body mass index is a risk factor for acute radiation skin reactions. And also smoking, age, different skin types, comorbidity, even alcohol consumption has been showed in some studies, but also a genetic variation. But I will come back a little bit to the risk factors or the patient-related risk factors. We did a study that we published a couple of years ago on 390 women with breast cancer that underwent adjuvant radiotherapy. And some of them had chemotherapy or hormone therapy according to existing guidelines. And we assessed the skins, and we used an assessment tool. So the staff used an assessment tool, and the patients also reported symptoms. And we looked at health-related quality of life, we looked at sleep disturbance, we collected clinical data on smoking status. We even tested that the patients were, if the patients were smokers or not, so it wasn't self-reported data. And we also looked at treatment data and body mass index. And the result in that study showed that 21% had severe skin reactions at follow-up, which was 10 days after the treatment. And of course, the total radiotherapy dose was a risk factor, and also high body mass index, older age, and smoking. Those four showed statistically significant association with severe reactions. And high body mass index and smoking were the strongest factors, and smoking actually was a twofold risk compared to non-smokers. And not surprisingly, patients with severe reactions reported higher levels of pain and increased sleeping problems. And these results have been confirmed in two larger recent studies as well, all on breast cancer. And I should say that a lot of studies on skin reactions in radiotherapy is done on patients with breast cancer, because the treatment procedures are quite standardized compared to many other treatments. So it's easier to perform your research. Okay, any questions?
I have one question, Lena, but it's about treatment, so I think you're going to talk about that in a minute, how you treat the skin reactions.
Okay, so we come back to that?
Yes.
And we come back to that now, actually. So how do you manage acute radiation skin reactions? Well, there's been quite a lot of research the last 10-15 years. And to sum it up, few or even no skincare products are effective in preventing or reducing acute radiation skin reactions. There's a lot of non-evaluated products for skincare being used. A lot of centers have local remedies that they use and really believe in, but they've not been tested. So it's a great variation in practice. And it seems it's always difficult to stop old habits, but in this area it seems to be even harder. I think we want to give the patients a solution and help them, so we are trying to be creative here, but there's a lot of things that doesn't seem to help. And what seems to help is more the very often basic strategies to keep the skin clean with soap and water and things like that, more than what type of cream you use. But I will discuss the different creams. But first, the goals with skincare on irradiated skin should be to keep the skin clean and to control the pain and try to create comfort and to avoid the friction and trauma from weather and wind and everything, clothes and stuff like that, and also to prevent infections, because that's when it can be really difficult. And the skincare is, like I said, about pain management. Also, nutrition is important. It's important to keep good conditions for wound healing, for instance. Smoking cessation is one of the most important things, or the best things a patient can do to reduce their own risk for severe reactions. And also, even if the evidence is not very strong, you should be careful with sun exposure, the hygiene, of course, and to avoid skincare products just before the daily treatments. Again, there's no strong evidence in the literature for that, but you should be careful with your skin in relation to radiotherapy, so that's what we still recommend. And to avoid makeup on the irradiated skin during your sessions, and to use electric razors rather than manual ones. So what skincare products should we use? Well, first of all, soap and water. There is several studies showing that soap and water is better than only water. And what soap you use doesn't really matter so much, as long as it's a mild soap. And what is a mild soap? Well, a lot of the most commercial soaps have been tested, and it doesn't seem to matter so much. I think you should be careful with something that's very perfumed. So try something that's doesn't have strong perfume in it, but otherwise it doesn't seem to matter. Soap and water seem to work, because if you only use water, there's a higher risk of developing moist desquamations. And most of the products that have been tested, as I said, show no effect. For instance, aloe vera products or chamomile products. And there's also a whole line of products that show conflicting results. Hyaluronic acid cream, for instance, steroid creams, topical steroids. I will come back to that because many centers use that. Calendula cream is also conflicting results. We have some studies from my department that I will come back to there as well. And just when I was preparing for this session, I looked at the recent studies published last year, and there is, even if these studies are all small and they're all single studies, but one study showed that olive oil reduced the risk of severe reactions. Another study showed that sandalwood oil and turmeric-based creams reduced the risk. And a third one, Boswellia-based cream, which I hardly know what it is, but it showed some effect. So a lot of things tested. And also the question is, should you use any kind of lotion or cream, or doesn't it matter? And that is a question, because there is at least one study published that had a third treatment arm in the study with no cream, and that showed that it didn't matter if you used a lotion or no lotion. On the other hand, it doesn't hurt to use a lotion, and I think it could be a good way of keeping the skin soft, and it might keep the skin intact for a longer time, but we don't really know enough to say so much about that. One of the studies that we did was we compared calendula cream, which is a cream that contains marigold plant extract, versus an aqueous water-based cream that was standard care at our department. And this was a blinded study with breast cancer patients. We looked at we assessed the skin, and we asked the patient to report symptoms. We looked at quality of life, smoking status, and we also asked the patients to describe their experiences of the two different products that we used in the study. And we found no statistically significant differences between those two creams. Actually, it was slightly higher, but not significantly higher severe reactions with the calendula cream compared with our plain, very basic, cheap Essex cream. It was more difficult to apply the calendula cream, and of course also it cost much more than the cheapest basic cream you have. So that's a study we published a couple of years ago. When it comes to topical steroids, that is a hot topic. There's been quite a few studies, and there is conflicting data. Up to a few years ago, it was really difficult to say so much about this, because there were studies showing completely different results. But there is studies showing that topical steroids can reduce itching and erythema in some studies, but not pain or most desquamation, which is two big problems. And also, there is very little data on long-time effect, on the effect of long-time use of topical steroids on irradiated skin. The latest study from 2014 showed that if you use topical steroids from the beginning, from the onset on radiotherapy, it actually improves the quality of life even. But still, we don't know, and in that's only one study, and in that study as well, there was very few severe reaction in both groups, in the placebo group as well. So I would recommend, but here you can get a different recommendation from different researchers. I would recommend that you shouldn't use topical steroids generally for everyone. Look at the risk factors and assess the risk and use it if you have to, but not for everyone all the time. And then it's the issue with deodorant. Could breast cancer patients use deodorant if the axilla is irradiated? There was a study on compliance from 2009, and that study showed that compliance was quite poor, and with the advice that we give patients, so they don't actually do exactly what we tell them to do, and not using deodorant, which is a recommendation that many centers give their patients. That was a big concern. And you only have to think about that yourself, not using deodorants during 5 or 6 weeks of radiotherapy. But there's been 2 small randomized trials. One when they compared aluminum-free deodorant with no deodorant, and they found no difference. And another study where they compared aluminum-based deodorant with non-aluminum-based deodorant, and they found no differences. So my recommendation is that it's okay to use deodorant as long as the skin is intact. I mean, if the skin is broken, you probably don't want to use deodorant there anyway. And another thing you can do is use the soft silicone dressings. They can help prevent trauma and friction. There's only small studies here as well. And the same goes with silver dressings or silver creams, that there's studies showing benefits and there's other studies not showing benefits, but no harm has been shown, so you can use those. When it comes to the silicone dressings, you can leave them on during the radiotherapy in most cases, but you should have a close you should have a discussion with the radiotherapy team so they know what you're doing. And you might wonder, isn't there a risk for an increased dose to the skin if you leave it on during treatment? And there is a risk, but it's not the clinical relevant one. It's been tests done, and these type of dressings increase the skin dose much less than, for instance, an immobilization device would do. One of the problems with these type of dressings is that they are expensive, and it's not they're not available for all patients. Any more questions?
Yes, you have a few questions.
Okay.
Lena. So one question is, do you think that IMRT is more effective in the prevention of acute radiation skin reactions than 3D-RT?
Yes, yes, I think so. But I also think that you have to take a lot in consideration, because you need to, if you used IMRT for all your patients, for instance, all your breast patients, you have slightly longer treatment times, and you have problems like that. So I think it would be better for the skin, definitely.
The next question is about, is the pH of the soap relevant? And if yes, what is the evidence for optimal pH for soap?
Good question. It doesn't seem to matter, because there is a study where they tested, like I said, the 15 most common soaps available on the market, and you would know most of them. They're sort of international brands, and some of them they all had different pH, and it didn't seem to matter. I think we put too much focus on things like that, actually.
The next question is about steroid therapy. Is it really not applicable?
What was that?
Steroid therapy, is it really not applicable?
Well, as I said, you can definitely use it, but I don't think you should recommend it for all the patients from onset. for instance, like I said, there is not a lot of data on the long-term use. Maybe you shouldn't use it from the beginning. You should use it if you see that early in the treatment the patients seem to develop severe reactions. Or if you have other risk factors, or depending on the dose. I don't think you should use it as in general, but it definitely is studies showing that it might improve quality of life and itching and things like that. But my advice is not for general use.
I suppose this is one of my own comments, Lena. If what you're trying to solve is itching, would you be better using an antihistamine rather than using a cream directly onto the skin, if it's appropriate for that patient?
Yes. Yeah. Good idea.
So, okay, we're getting a lot of questions here, Lena. Oh. So the next question is soft silicone dressings. There are a variety of them, Mepilex products. Are there recommendations? There is one related to prevention of radiodermatitis. Do you have experience about it?
No, I know that Mepilex ones are used for that, but if that's the person who asked the question mean or not, I'm not sure which product. To be honest, the studies that's been done that I've seen is about the Mepilex, but I don't think it matters which one you use. They're probably very similar, is what I guess. But I've not used all of them, so they could be local in different countries as well.
Of course, and your point is right that because they are expensive, they're not available across centres, so maybe that's a factor. Yeah. The next one is a statement really saying that they're still using gamma therapy.
Okay.
Skin reactions.
Okay.
Okay, I think that's all the questions at the minute.
Okay. So if we start with then the treatment of erythema, we pretty much said this already. Wash the skin with mild soap and water daily, and use a perfume-free lotion. That's my recommendation. And you see here on this picture that you can have many degrees of reactions at the same time. You see here both erythema and dry desquamation, and that's very typical that you see, and sometimes even moist desquamation in the same area. And dry desquamation, same thing. Use silicone dressing or silver if you want. With silver, you should not put it on and let it stay on during the treatment, because as far as I know, none of the tests have been done with those type of dressings. Nothing that's been published anyway. Here it's avoiding friction and trauma, and you see this left picture here, like the color of a shirt or a jacket or something can be irritating. So think about comfort and try to put something soft closest to the skin. And that's when the silicone dressings can be good as well, because they cover the irradiated area, so it prevents friction. And when you see moist desquamations, same advice really, and make sure that you treat infections, because very often when you see as on this top picture, this is a bad infection, and that needs to be treated with antibiotics. Okay, I want to continue and talk a little bit about combined treatments as well, radiotherapy and targeted drugs. I think you all know the symptoms that you get from targeted drugs, and the combination with radiotherapy is something you have to consider, because on these two pictures, these two men have had exactly the same treatment. They've had cetuximab, 4 cycles of cetuximab and 38 grays of radiotherapy. And the bottom picture is those red marks that you see. The only sort of skin rash you see there is the only thing you could see on that patient. In his face, that it was head and neck patient. He didn't have any reaction. And on the top picture, you see the reaction, and you see on his chin, you see the line where the radiotherapy fields, the edge of the radiotherapy field. So that's how different it could be for different patients. And you need to treat this with antibiotics straight away, as early as you can when you see these reactions, because it's even more important that you try to avoid treatment interruptions for the patients with combined treatments. Think about many of the patients with colorectal cancer, for instance, that have targeted therapies. They get advised to cover up the reactions with makeup and make sure you think about if it's head and neck patients or patients that get irradiated at the same time. They should not put makeup on the irradiated skin, so be careful about that. One of the problems with the combined treatments is you see more severe skin reactions, even if we didn't see it in our study on breast cancer. But typically when you have higher doses of radiotherapy, you see more reactions. And you also see a different pattern, because the reaction from the targeted drugs can start much earlier. So you see different patterns from the targeted drugs and the radiotherapy. And also, we don't know enough of the late toxicity with this combination because we've not used it for that long. And it's limited evidence for management. But I actually found one paper that's just come out from Russi et al. It's been published in the Critical Review in Oncology Hematology, now 2015. And that is a literature review and consensus about head and neck cancer patients treated with radiotherapy and chemotherapy or EGFR inhibitors. So that's quite interesting if you are interested in that, or if you treat those patients. Any more questions?
Yes, so we're going back to the steroid creams. So one institution uses them to all their patients, and they feel that it has a high effect. But I think you've answered that in relation to the evidence, and I suppose that's part of the problem in terms of what you said at the beginning. Practice versus evidence. So I'll move on to the next question. What about creams with other types of metals?
Well, is it any particular metal? I mean, there is all the creams have not been tested, so it's very difficult to say. But in general, it doesn't seem to matter. The ones that they tested with metal, it doesn't seem to matter so much.
The next question is about a patient who has skin cancer on the buccal region. Do they have to shave every day when they have an acute skin reaction? They're having gamma radiotherapy.
No, not at all. The skin will fall off anyway, so I don't think so. It's sort of takes care of itself if you go into the treatment long enough. So no, not at all.
Okay, patients who are on Androcur don't have any skin reaction. Is it normal? Again, a patient having gamma therapy.
Oh, say that again.
A patient with hormone therapy for testicular cancer and they don't get a skin reaction. Is it normal?
Is it normal not to get the skin reaction?
Yeah.
Well,
exactly.
you don't get that high dose, so I suppose it's normal. Yeah.
The next question is related to recall reactions of skin reactions with doxorubicin. Is there any literature about the management?
Not that I know of, actually. I don't know of any papers that looked at that.
Okay. And the next question has just come in saying that they do give high-dose radiotherapy to the testes.
Okay. Well, then they probably know better than I, because I don't know that. Sorry.
Okay. That's the end of the question.
Okay, should we continue? Yeah.
Yeah.
Just a few words on late skin toxicity. That is also something that's more unusual today because we really strive to reduce the risk during the 3D or 4D planning phase, but it's difficult or impossible to completely avoid the risk. The patients we see today, with late skin toxicity, they had normally had their radiation therapy a long time ago. But what we see is increased pigmentation, reduced elasticity, telangiectacy, that is very difficult to say when you're Swedish, and alopecia. And what we know is that smoking is also an increased or a risk factor for late skin toxicity. And I want to sum up a little bit and talk a little bit about skin assessment. I might change from most assessment tools to some, at least. Many of the assessment tools that we use are not validated. And so we have to be a little bit careful and not sort of trust an assessment tool so much. An assessment should include or be combined with patients reporting data, because we have to remember that it's not how red the skin is that's important, or at least not most important, is how the reaction affects the patient and their symptoms. And you should assess the skin before, during, and after treatment, so you can compare, so you know how it looked before the treatment started and during and after. And something you need to consider as well that we found in one of our studies was that you have to look at the inter-observer agreement. So how big difference, how do we use the different assessment tools? We tested 2 different tools, and we did 2 extremely experienced nurses, but they did their assessments at the same, just after each other at the same dates, but independently. And we found an inter-observer agreement of 50 to 60% just. And sometimes the assessment, the difference was actually 2 scales. So it's 2 steps on a scale. And when we looked at the reasons for this was that many nurses seem to look at the redness, how intense the redness is, and then you say, well, that must be a grade 3, for instance. But it might be a grade 1, depending on the scale you use. So if you really study the assessment tool, and so education is essential. After these results, we had workshops with all the staff and discussed and teach them the tools that we've used, and we could improve their inter-observer agreement a great deal after that. So it's important to think about that as well. And that finally, some take-home messages. And that is that most patients experience acute skin reactions from radiotherapy, most of them mild to moderate, but the ones that have more severe reactions are really problematic. And to keep the skin clean with soap and water. And there is a lot of local remedies used or different products, and there's little or no evidence. And there's no strong evidence in favor of any of the skincare products. And what we can recommend and help the patients with is actually smoking. It's one of the most important risk factors. High BMI as well. On the other hand, you don't want your patients to lose a lot of weight during the radiotherapy session because that might also affect the dose distribution. So, but smoking is really a teachable moment that you can use for your patients, especially if you meet them before they start the therapy as well. And we have done studies on that as well, and we see that you can be very successful with smoking cessation programs in relationship to radiotherapy. And that was the final slide. Any more questions?
Yes, the next question is lymphedema a late reaction after breast irradiation for breast cancer?
It can be both. It can be from the cancer and from the operation and from the radiotherapy. So yeah, it can be.
What do you recommend online education tools, assessment by picture, specific things to avoid long or redundant, confusing descriptions? Do you have any specific education tool?
Well, I think you should look at your clinic or your department to see, is there anything that's already been used? Is it a department that do a lot of research for maybe not for skincare, but do a lot of research in other areas and are assessing skin already? Look at that. So start with that. Otherwise, one scale that both look at patient symptoms and sort of the staff assessing the skin is the RISRAS scale. Can be recommended. We have used RTOG, EORTC scales. That's been used a lot in Europe, and we use them, and that's the one we used in the study where we had 50% inter-observer agreement, but after teaching the staff and having workshop, we came up to close to 90% inter-observer agreement, and they've been tested. So those I can say. But the important thing is to include patient-reported symptoms. The EORTC does not include patient-reported symptoms, so then you have to ask patients anyway.
And what would you suggest for that? Is it a visual analog or?
Yes, why not?
I think that's all the questions. Oh, there's another one coming through. I had a few of my own for you anyway, Lena.
Yeah.
What about studies, hyperfractionated radiotherapy on mammary gland? I heard about low toxicities and low skin reactions.
Yes, there is. The fractionation scheme affects it as well. I've not read up completely on those studies, but I know that in many centers use hyperfractionated breast treatments already, and it seems to be there's quite a lot of evidence for that.
And then somebody actually asked, what about patient report assessment, physical or online? But I think you've answered that with visual analog. Okay, I just had a question, Lena, about areas that you can't apply dressings to, particularly, the rectal or gynae cancers that develop quite a severe skin reaction.
Yeah.
How would you suggest that they be managed?
That is really, really difficult. We have used a lot of the silicone dressings there as well. I mean, it doesn't work perfect because they will fall off and you need to change them, but you need to change them several times a day anyway in that area. So, and there's different sprays and things like that could be used after the treatment period. But during the treatment period, you can't really use it because then you have to rub the skin to get rid of sprays and stuff. So, and try to put dressings, also gauze or something between in skin folds to try to avoid the skin-to-skin contact. Clean hand showers, shower and keep the skin clean. So it's really difficult to treat. And I mean those. That area is so difficult to keep clean during this period, but it's so important. So it's the same kind of
practical
management,
advice.
yes, but it's more difficult.
Just because we can see it in the questions coming through about different institutional policies, and I suppose given the variation in practice that you said and the lack of empirical evidence of one product over another, it is quite difficult to develop institutional guidelines, isn't it? Have you any recommendations for people, or is it just a consensus document?
Yes, and keep it simple. And remember as well that what I'm not saying is that you shouldn't. It's so many things that it doesn't show to be beneficial, but it doesn't show any harm either. So if you have something you use for a long time, it seems to work. Of course, you should not tell patients that to use things that if they're not effective and they're very expensive or difficult to get to. But I would say any type of sort of moisturizer that seems to work, you can use, and use the local products available. Another tip is that to ask the patients what they normally use. A lot of it's talking about compliance. It's easier to get patients to use the skincare products they're already using. So depending on what they're using, if they have a basic lotion they use that's perfume-free, they can probably continue with that. I think we put too much focus on what type of cream that it seems to not matter so much what cream it is.
And I suppose the other issue is that it can be hard to standardize practices because a lot of products come out every day nearly, and obviously companies are trying to sell products, and they'll come in with different types of products every day to you. But your advice is that generally, if it doesn't cause harm, then that it is okay to use.
Yes, definitely.
Okay, I just have a final check of the questions. You got a thank you and an exclamation mark. What about the use of sucralfate in ulcerated lesions from radiodermatitis or mucositis? Is there any evidence?
Well, there is a very well-designed study from the UK that show no evidence, and it's a study by Mary Wells et al. So that's the only study, I think. That's the study with 3 arms, and 1 arm was no cream at all. But it was colorectal and breast cancer patients and 350 patients, something like that. So that showed no evidence.
Is there a recommendation on when the patient should start applying skincare products, i.e. before or after the onset of a skin reaction?
There's no strong evidence there either, I'm sorry. But I would say start when the treatment starts. And it's also a good way of keeping an eye on the skin and looking for reactions early and keeping the skin soft and that. But if you forgot and if you not do it, it probably doesn't matter so much. So we have to remember that the effect on the skin is caused by the radiotherapy, and whatever we do, the sort of process in the skin will continue. So it's regarding products, it's very little we can do. So focus a lot on smoking cessation is my strongest advice.
And I mean, they are short-term acute reactions. They will heal up after radiotherapy is complete, regardless nearly of what product you use, isn't it? Yeah.
And try to help the patients to continue so you don't have treatment interruptions.
Exactly, yeah. Okay, I think we're at the end of the questions, Lena.
Okay, thank you very much, everyone.
Thank you very much. Yeah. And thank you. We had really good participation, so thank you very much to everybody who submitted questions online and generated a good discussion.
Yeah, perfect. Thank you very much.
Thank you, Dr. Sharp, and thank you, Mrs. Leonard.